Pallavi madam, you can go YouTube live.
Yes, sir. We are live now. Kindly
Oh,
start. Thank you.
Good evening, everyone. Myself, Dr. Hadika Rathé, and I will be presenting the long case today. My case is a 7-year, 9-month-old male child, second by birth daughter, born out of non-consanguineous marriage, resident of and hailing from Aurangabad, Muslim by religion, brought by and informed by mother, being reliable, came with complaint of cola-colored urine since 8 days, fever since 4 days, and paucity of movement in right side, upper limb and lower limb since 2 days. Uh, There is history of early morning first urine being cola colored, not associated with burning sensation or pain. There are history of repeated episode of similar complaints in past, which resolved after some oral medication advised to be taken with milk and reappeared since 8 days, as mother stopped the medication on her own 8 days back. Fever is undocumented, high grade, not associated with chills, rigor, rash, relieved on medication, then reoccur. Child being inactive in interfebrile period. Child is a left-handed person, was apparently all right when started complaining of weakness in right upper limb and lower limb associated with tingling sensation. Mother observed child dragging leg with losing of sleepers while walking and unable to lift things with right hand, followed by unable to take hand overhead. Over next one day, child was unable to roll over or get up from the sleeping position. Mother also observed that child could not feel the pinching over the right upper limb and lower limb. There was deviation of angle of mouth was also observed towards the left side. On inquiry, mother told that multiple episodes of weakness were observed in last 2 months, usually precipitated by some illness like LRTI or URTI, resolving on its own within 15 minutes with no focal neurological deficit observed. There is no history of blurring of vision, vomiting, headache, bowel bladder incontinence, altered sensorium, loss of consciousness, seizures, trauma, cyanosis or repeated LRTI, difficulty in swallowing or drooling of saliva, history of blood transfusions or blood disorders in family, and Cox content. Child has a significant past history. Child was admitted last year in June at Aurangabad Hospital with complaint of yellowish discoloration of eyes and distended abdomen. Some blood investigations were done and told to have enlarged spleen, requiring transfusion and started on some oral medication, then discharged. In last 7 to 8 months since diagnosis, child has received total 25 PRC transfusions. ANC and birth history being uneventful. Uh, Development is appropriate for age. Dietary history, mixed diet, it's from family food. Family history, uh, child has two other siblings, one 10-year and the other 7-year, 9-month old. Uh, all are normal. There is some family discordance with one abortion 3 month of age. Uh,
so this roughly 7 year, 9 months, roughly 8-year-old girl has come with cola colored urine since 8 days, fever since 4 days, and then paucity of movement. So what is your first thought when you have this presenting complaints?
there is some blood disorder that is leading to this cola colored urine and this weakness of limb.
So why? So hematuria, what is the commonest cause that you see in pediatrics which presents as hematuria? So blood disorders come to us for hematuria.
Urinary tract infections can cause hematuria, but it is cola colored. So it is suggestive of glomerular uh, affection. So something, uh, it is not local cause, which will lead to fresh color, fresh red colored hematuria. There is some blood disorder and ocular history also, sir.
No. So see, we are learning how to think. So that subsequent history we will connect or we will take it later. What we have to think is with these complaints, how should we progress? So suppose, yeah,
First 4 days.
Glomerular cause of
correct, glomerular cause. And what is the commonest cause for coming with Kogola color?
post
Post-streptococcal glomerulonephritis, first class. So first thought is this is a glomerular bleeding, and therefore whether this is some glomerulonephritis. Now tell me what is odd or what strikes you as not fitting into the PSGN.
being coming after the
Very good. So fever coming after 3 4 days is funny. So you are wondering. So that day when you first saw on 3 days, you might have said, okay, this is classical glomerulonephritis, but you would have looked for a few things. What all would you have looked for?
fever, any skin infection, and URTI in last 14 days. Um,
And now
now the
some mild edema, hypertension, oliguria, you would have looked for all that, right? Okay. Now the fever has come after 3 4 days, so that makes you wonder ki why this sequence, right? Now, what about the paucity of movement?
One. Painless hematuria and painless, painful hematuria. That's your first thing. This is painless. It is not coming from bladder or there is a local problem there or any of those cystitis, etc. So first start with painless or painful. This is painless, therefore coming high.
She also said cola colored, so which means it is glomerulus, right?
Can cola colored urine, can glomerular disease not give rise to cola colored even if there is hematuria?
Sir, if there is microhematuria,
Previously, we were told that a smoky urine, which may not have RBCs, can color. So don't be carried away with that hematuria has to be cola color. There can be a smoky urine or just a little tinge of blood, and still it is hematuria.
So now what about this paucity of movement? Any thoughts?
sir, till this, for the first two complaints, we were thinking of renal maybe, but after this paucity of movements, it can be some vessel related also.
Yeah. So for the first two complaints, renal as in what are you thinking renal? Means what is the change in thinking from that typical jumping to a post-streptococcal glomerulonephritis? You said fever came later. What does that mean to you?
classical PSGN case, there has to be 2 weeks prior or 4 weeks prior, like skin infection 4 weeks. And if you are LRTI, it will be 2 weeks prior. We expect an infection leading to a cross-reactivity and leading to the PSGN picture, not the fever coming like that. Mm.
Suppose in PSGN you get fever. Is that fever a infection today? Suppose today a child with PSGN comes with fever and hematuria. Is that an infection today? Why is he getting fever?
Inflammatory cause can be there.
Correct. So it's not a infection today anyway. So that 2 week old history is just a supportive thing, right? So here again, this fever is obviously non-infective. It is immune mediated or inflammatory fever, and it probably already tells you that maybe this is a disorder which is some glomerulonephritis, but other than PSGN, immune mediated, which means that you possibly expect something in the past, right? Come ahead here. Come.
I think in this child, the first 4 days, the only symptom was hematuria. Okay. Now, hematuria is a glomerular. But which part of the glomerular? You have an endothelium, epithelium, and interstitium. If it was endothelial, there would have been mild edema, hypertension, okay, oliguria. This child did not complain of that. Sometimes the first symptom may be hematuria, but soon followed by a few hours, notice edema, hypertension, etc. These 4 days have gone without progress, and therefore this is not endothelial glomerulonephritis. A typical epithelial glomerulonephritis is a nephrotic syndrome prototype. There is rarely a hematuria there. Therefore, this is an interstitial nephritis. Okay. Moment you say interstitial nephritis, then the causes are either drug induced or an immune. Infection is out. Okay. And therefore, at that stage, I would have said you have an interstitial nephritis and we don't know what's going to happen thereafter. Interstitial nephritis may be recurrent. We have had presentation of such a cases. And therefore, we don't know whether it will resolve by itself or it will complicate into further renal dysfunction. At that stage, we don't know. So we are only observing. And what are we observing? Enough urine output. Serum creatinine is not going up. Okay. Urine is not showing proteins, which means there is no other damage. At that stage, you start getting fever. Now the whole process is same. The disease is same. The symptom is different. So what's our first impression? Immune mediated interstitial nephritis. So now the same is causing fever. So fever is an immunological inflammation. But why did the fever come later? Okay, if it was an immune inflammation, interstitial nephritis, which to my mind is immune mediated disorder is spreading over. That means it is not only restricted to interstitial nephritis, but it is spreading. And what is spreading? Inflammatory response is becoming severe. Now, what is severe in this situation? Not increase in hematuria. So possibly spread to other organs. But at that stage, we don't know which other organ at all. Till the positive moment came, and you say, oh, this is a vasculitis. We are talking about the same. When I said interstitial nephritis causing hematuria, it's a blood vessel which is bleeding, which means the vasculature in the interstitium of the kidney is bleeding. So it's a vasculitis. Now you have another vasculitis and a fever. So the whole story suggests that started with interstitial nephritis, but is spreading, inflammation is spreading. That means this is something which is worsening over time. And therefore we want to watch what is happening next. Right? And so far so good. You have another vasculitis coming up there neurologically, the fever. Now, whenever you have such a symptom of 8 days now, you need to tell us the progression. Origin, duration, progress. Okay. Has the fever disappeared or it's still persisting? Okay. Disappeared.
Disappeared.
Wonderful. We know it's immune. How will it disappear otherwise? Okay. Has the hematuria been clearing up? So each point will be important. Now, if fever has disappeared, that means inflammation is under control by nature. Unless somebody gives some drugs, that's a different story. But if you look at the natural story, that means the spreading inflammation seems to be under control. That means this is likely to naturally recover, whatever the main cause might be. Similarly, if hematuria was getting more, its urine was getting clearer, he would have said, oh, even that is improving, though there is another vasculitic event coming up. And that could have made us even suspect only with the first slide that you have a sudden appearance of an immune mediated vasculitis in the interstitium of the glomerulus, and it is already recovering by nature. You would have got so much of information, right? So that's why origin, duration, progress of every symptom is important, right?
So there was a question. So can this be hemoglobinuria due to intravascular hemolysis? So what are your thoughts on that? This is the way this child has presented. So can this be intravascular hemolysis and hemoglobinuria? Any thoughts on that? So we'll give you clues. So when do you get intravascular hemolysis? Think of 2, 3 situations where you know that there can be intravascular hemolysis.
Microscopic.
Anything else? Autoimmune, you are saying, no? Some autoimmune condition. Paroxysmal nocturnal hemoglobinuria. Okay. Anything else? Any acute conditions? Rhabdomyolysis. Okay, where there's myoglobinuria. So when do you get rhabdomyolysis? So massive trauma or a massive illness. So that would precede that. Anything else? So G6PD, where again it would be a sick child. Falciparum malaria, again a sick child, right? Then transfusion
Mismatch
reaction,
transfusion.
a sick child. So I'm trying to say that all the sick situations can be ruled out. These other rare hematological conditions, we can't say. Okay, just for that hemoglobinuria as a cause of that cola-colored urine.
But when there is the RBC's lights and hemoglobin is destroyed, you don't get all that kind of a urinary change. You have a hemolytic anemia. Now, where is the urine? RBCs are breaking down. So then what's the difference between hemoglobinuria and still a hemolytic anemia? And the difference is hemoglobinuria is an intravascular destruction. And when there's an intravascular destruction, the patient will come with pallor and sickness. Whereas the hemolysis is an extravascular, then there is nothing happening in the urine. And that's why that sickness comes in. So this is not hemoglobinuria, but good point that he made out that. And how would you differentiate between hemoglobinuria and hematuria? Both look red. Any idea? A simple investigation.
Urine routine will tell you what.
Benzidine positive in both.
So after centrifusion, the RBC will settle down.
So in one, the RBCs are fresh, another RBCs are cremated, destroyed RBCs. Okay. So this is hematuria for all practical purposes, right?
Sir, another question. Can this be some, thrombosis or embolism, where even CNS there is a thrombus oblique embolism, in the kidney also there is a thrombus which is causing this bleeding or cola colored urine.
I think largely I would say that if it was any thrombotic phenomena, then the renal function would have been upset. This child's renal function is not upset as of now. And therefore, I put it as an interstitial involvement. Otherwise, had it been an endothelial or epithelial, you would have run fast into a renal dysfunction.
We take a classical example of renal vein thrombosis in the case of nephrotic, where there is thrombosis and there could be hematuria, but it is associated with pain. There is a predisposing factor. The kidney may be enlarged in size. I'm taking just one example. One has not seen so many. So this part of history is absent here. This is something like from nowhere the hemoglobinuria has started, painless, coming suddenly, and we saw later may even disappear.
Sir, the renal vein thrombosis, of course, is like the main vein is getting thrombosed. But suppose you have smaller thrombi getting into the smaller circulation, like you had the CNS event. So, means I was just discussing whether that is a possibility. Main
Like-
vein, of course,
You mean like subacute endocarditis?
no, means for example, like say theoretically for their discussion, suppose it's a sickle cell and they've got multiple occlusion of renal vessels, smaller, not the main vein, and an occlusion of a vessel in the CNS. We're just discussing for discussion's sake.
Typical such issues don't happen at multiple areas. Sickle cell hepatopathy or whatever is at one area. There's no reason why suddenly the sickle cells are getting blocked in multiple sites, like a moya moya, for example. So possibly, yes, it's a good point to discuss. But possibly in this child, it is vasculitis only.
Okay, now, what do you make out of this past history? Uh, urine being cola colored and similar episodes in the past resolved with some oral medication. Advice to be taken with milk reappeared 8 days after mother has stopped. So, what do you think that medication is? Steroid. So, now what do you make out of this? Nothing. It's just that we already said this is a immune mediated uh, interstitial nephritis right now. So, this is in line with that, that this child has been treated with steroid for some immune mediated nephritis.
One point is that the medicine worked and the mother stopped medicine. But did the child remain well for a long time? That means it was not probably the drug, but it was the natural cause.
No, sir, like she stopped it and the next day it all started.
Okay, so if the drug was stopped and immediately the things came up, then possibly the drug was working. But otherwise, it could be a natural phenomenon.
Sir, even then, that's too much of a coincidence. No? How long was she on those medicines?
Since last 7 months, the child was on medication. Since the child was diagnosed in last June, July, then he was on the medication. Last 8 days, she stopped it, and the next day morning,
Just
the
8
child
days.
started something. Intermittently, also there were some episodes. At those time, also there was some non-compliance with the drugs associated.
So basically, over the 7 months, also the drug has been irregular. I'm just saying that just as a thought process, if somebody has been taking steroids for 7 months and he stops next day, you don't get hematuria
7
because he
months
stopped.
looks very unusual. Typically, nephrotic syndrome who also needs a long-term steroid therapy in a steroid dependent does not go on with the full dose like that. So we need to confirm again. How would you have confirmed in the history that you was taking it for 7 days, 7 months? Because the mother
History.
said 7 months. How did you confirm?
Come on, you all also speak. Everyone participates, so
Okay,
you
mother
learn
said-
better.
Mother said 7 months of steroid. And I want to ask more questions in the history to make sure whether it is 7 months or 7 days.
Has there been a weight gain associated?
Weight gain.
Good. And therefore, steroid effect and thereafter steroid side effects. What's the difference between the two? One is effect, another is side effect. Incidentally, what is side effect? Which side? Left side, right side? Which side? And that side means different organ other than for which you are giving. Okay. And and therefore you would have looked up, okay, many thing she's right. Weight gain, almost obesity, 7 months. If you apply steroid ointment to a weeping eczema in a small infant, he would gain 2 kilos because skin will absorb a lot. So possibly we'll have to check on all this, right? But we know that it was recovering on treatment naturally or otherwise.
Okay. And then this lost right-sided hemiparesis, right? Which came up. So,
We have a sensory loss also. Why is that? That means nerves are involved. Any idea? Does does a typical intern capsule MCA infarct has a sensory involvement? Answer is yes. Yeah. It's often not noticed. Why should it not involve? MCA is supplying a large area, especially with the stem itself. Then you have a sensory issues also. But generally, what we see by the time the patient comes to us are the motor symptoms. But if you look at the book, even the sensory system is affected in a typical MCA head, right? And therefore, that does not bother me a great deal. Okay, and you can't go on to the peripheral, but on examination, you might find peripheral, which means that the nerves are also involved besides the CNS. That is different.
now what do you make out of this? Mothers had multiple episodes of weakness in last 2 months, usually preceded by some illness, resolving on its own within 15 minutes with no focal neurological deficit. So what are your thoughts on this? What kind of weakness? Weakness of hands and legs.
Psychogenic.
Heaviness, a complaint of a heaviness. He could not pick up things and would feel a tingling sensation. And that's why they, in the initial, with this event, they ignored it because it was heaviness and tingling, which was observed since last 2 months also. Sir. But it used to resolve and there was no focal deficit observed.
So what are your thoughts? What could this be? Sir is saying, is it psychogenic? Transient ischemic attack. Okay. Due to what?
Resolving in 15 minutes.
Due to what?
Psychogenic.
So what can cause a TIA?
Microthrombin.
Gets dislodged. What else? Spasm. Very good. Yeah. So these are some possibilities why there could have been TIAs.
And I think typical vasospasm, which comes up and disappears again, is a metabolic form. Now, what metabolic abnormality is causing that is the next situation. But therefore, we know that this child has not only some vasculitis, which seems to be recovering by itself, okay, and naturally recovering. That puts us to a first statement that we are discussing that steroid long term may not be required in this child, and steroid for a short time she must have stopped, and it came again by chance, and then it was thought that it was probably not. So we keep options open, but we know a naturally recovering vascular illness, right?
Now,
Yeah, transfusion.
now this admitted last year with yellowish discoloration of eyes, distended abdomen, enlarged spleen, requiring PRC transfusion, and total 25 transfusions since diagnosis. What does this tell you? How will you interpret this?
Hemolytic anemia is all.
One is hemolytic anemia. So, which hemolytic anemia requires? So, you're saying since last June means what? Over 1 year or over?
7 8 months.
So, in 8 months, which hemolytic anemia requires 25 PRC transfusions?
5 years of age. In an elderly child.
8-year-old girl.
Yeah.
Means even thalassemia doesn't require 25 transfusions in 6 months. So, which hemolytic anemia requires so much transfusion?
Sir, because they are giving the PRC and autoimmune causes, it is leading to hemolysis. And with no diagnosis, they were again transfusing the child. That's why there were 25 transfusions.
Very good. So, when there are so many transfusions, you almost wonder whether the transfused blood itself is getting hemolyzed, which means, as you rightly said, it is an autoimmune hemolytic anemia because you just can't have so much of transfusion requirement in any, even in bone marrow aplasia or even in a thalassemia, which is the maximum
But
requirement.
here again, you are not mentioning that patient presented with pallor. Jaundice comes hardly any. In a hemolytic situation, the presentation is pallor. Jaundice is often not complained of and picked up by the physician. Here, the complaint is there. So I wonder what kind of hemolysis this is. Okay, if there is no pallor, then it is liver. And if it is liver, then it's a vasculopathy in the liver, like a sickle. The 25 transfusion will leave for a while. That looks very unlikely. But the point is that how do we know it's a hemolysis? First thing is appeared for the first time in the life of this child at that age. So all congenital hereditary anemias are almost out. Okay. And presenting with jaundice, hemolytic anemia rarely presents with jaundice. Presents with
Which
only
hemolytic anemia will present with a spleen and jaundice? Very good. Hereditary spherocytosis. But they will not have all this other history that we are getting of cola colored urine and CNS event and all that, right?
So the point is, even if the mother says this, we could have had many questions to confirm whether she has misrepresented, okay, some of those facts. That is the important thing. Whereas by habit, we state in the first 4 lines, history written, given by the mother, reliable. Now, even if the mother wants to be reliable, she is honestly giving you wrong information. She is not dishonest. She feels this is the right. So we will have to be very sure whether the real history is reliable or not. And once we have discussed this, there would be reasons to kind of counter check with the parents to make sure whether it is reliable or not.
Now, summarize and tell us what.
So, sir, 7 year, 9 month old boy with sudden onset right-sided hemiparesis with left-sided facial deviation in known case of some blood disorder in birth and developmentally normal with fully immunized child with no seizures or altered sensorium is most probably a case of arterial ischemic stroke. Sir, it was autoimmune hemolytic anemia secondary to parvovirus. Uh,
So that is the final diagnosis you are saying. Yeah. No, but suppose we are in an exam here, how will you discuss or argue? We don't know the final diagnosis yet.
uh, is ischemic because it can be either hemolytic or ischemic. Yeah, hemolytic or ischemic. So hemolytic would have come up with a more severe course of convulsion, altered sensorium, and that's why thought of ischemic.
Hemorrhagic, you mean?
Yeah, hemorrhagic or ischemic. So ischemic was my first preferred because there was no altered sensorium, convulsion, or a severe cold. And arterial because vasculitis was explaining things. So arterial cause, initial cause of stroke.
Right. I'm not questioning the arterial ischemic stroke. That I'm not questioning. I'm saying let's think in the exam at this stage after history. What DDs can we give? So arterial ischemic stroke, fine. But what is the cause of ischemia? We started by saying that probably this is immune mediated vasculitis at multiple places. And then we got that kind of a odd event that somewhere last year this child has had a icterus spleen and needed PRC, and after that 25 PRC. So what happened after that? Okay, chalo, some sensitization of autoimmune hemolytic anemia. But that illness was what? And whether it is linked to all these vasculitis episodes. That is what we have to try and think, no? Because this child has been unwell. Means that event was the first event in the whole story.
Yes, sir.
That icterus and spleen was the first event in the whole story. Even the cola colored urine and all that came after that. Oh, so then you totally change the perspective of the thing. So then the cola colored urine and all is a react. It's after that. That is the primary event. No?
I think if the primary event is that spleen and all that, we already said that jaundice doesn't look like hemolytic. So we did not rush to say it was a hemolytic thing. And to that extent, could it be a hepatopathy? The point that I'm making is at the far total analysis, I feel there is a renal involvement, there is the CNS involvement, and there may be a hepatic involvement. We are not sure. In other words, there are multiple areas of involvement. That's number one. Second is things look recurrent and sudden appearance, sudden disappearance also, and recurrence. When you get this kind of a thing, metabolic comes high up, not even immune. Immune may recur, but not just sudden appearance and sudden disappearance. Okay. And it's not only vessel. So to that extent, I feel that multiple organs are involved, CNS is involved. So could it be a mitochondrial disorder? So mitochondrial disorder is a metabolic disorder, genetically determined. Now, some of these things are not fitting in, I understand, but we need much more clear information on that. But if you see a repeated episodes of vascular events, then I think it's a metabolic vascular disease that is also involving in some other organs. And we know that mitochondrial involvement, though predominantly occurs in organs which need a lot of energy, and the CNS is, of course, one, muscle, hepatic, but every organ is also involved because every organ needs mitochondria. So my question is, could it be a mitochondrial disease?
Sir, for a minute, suppose we look at it the other way, that till say 8, 9 months back, this child was bang normal, no complaints. Then that first illness where she's saying that there was icterus, abdominal distension, spleen, and PRC transfusion during that illness. The fact that they needed PRC transfusion during that illness, it was possibly some acute anemia. So possibly acute hemolytic acquired. So whatever is the reason that time for a acute acquired hemolytic anemia. And after that, there are multiple thrombotic or whatever episodes. Is this something to be?
I mean, I look at it in a little different way. This child required multiple transfusions.
Which
in short, so we are not sure about it. But what is lacking is the pallor is not mentioned at all.
No, agreed, sir.
Okay.
I'm saying
now
these.
just because there is jaundice And a jaundice child also might need some transfusion if there was an associated any other bleeding or whatever. We have no idea about it. So we are not clear about it. But to me, it did not look like, again, acute hemolytic anemia. What was the progress? In a typical acute hemolytic anemia autoimmune, you will have a quick reversal also. Spleen also will go down. But jaundice is not a presentation. Presentation is pallor. Okay. And therefore, and rarely it will need a blood transfusion. Even a acute hemolytic anemia rarely needs a blood transfusion. And there, if you need a blood transfusion, you will have to be very careful about the interaction between the donor's blood and the recipient blood. So, as you said, that could be the cause of multiple things.
Yeah.
But on the whole, to me, this doesn't look like a hemolytic anemia per se, just because splenomegaly. Okay, we don't know about hepatomegaly also.
No, I'm not, often I don't remember details, but there are some conditions where you would have a kind of a prothrombotic state associated with
Agree. Don't know.
this. So whether that is triggered or because those many episodes of TIAs also are very funny, whether they are
But that's why I mean, if at all between the two, thrombosis may not have multiple episodes, but the metabolic disorders could
may
have.
have, yeah.
And look at the MELA, for example, mitochondrial encephalopathy with lactic acidosis, multiple episodes. So to me, that fits in logically. We may be totally wrong, yes, but we'll know what.
Thrombotic also and multiple episode also, why it will always be at the same site, at the same
And I think this is suddenly recovering also. Okay. So that looks very different. If you have a thrombotic phenomenon, then why is it recovering so quickly? And multiple organs involved. So anyway, I think we are just debating. Let's see what.
on examination, child is lying comfortably in bed, is conscious oriented to time, place, and person. Heart rate was 140, RR was 40 per minute. Peripheral pulses and central pulses were well felt, extremities were warm. BP was maintained, taken in the left upper limb in supine position. There was pallor present, icterus present. Mild pallor and icterus present. Very evident.
Very,
Evident.
very
icterus.
obvious icterus. Okay.
Serous and mild pallor. That's hepatic.
In hemolytic, 3 plus pallor and 1 plus icterus. In the liver disease, 3 plus icterus and 1 pallor. So was the pallor severe? 1 plus, we don't understand. Mild, moderate, severe.
Actually,
And icterus was also mild, moderate, severe.
Trying to say that we are learning how to be more in detail about the history, etc. It doesn't matter, but we're just making a point that mild pallor and obvious jaundice is a hepatic disorder till proved otherwise.
there was no clubbing, cyanosis, lymphadenopathy, or edema. Anthropometrically, the child is normal. On head-to-toe examination, plateauia is present. Spine is normal, cafe is spot over right forearm. Then on systemic examination, higher mental function. Child is conscious, oriented to time, place, and person. Memory recent and remote intact. Attention span is good and normal speech is present. On cranial nerve examination, seventh nerve involvement is there, sir. On presentation, there was deviation of angle of mouth to the
Head
left.
is there.
On waist.
Okay.
There was deviation of angle of mouth to the left with loss of nasolabial fold on the right with frowning intact. So my impression was right, human facial nerve palsy. No other cranial nerve involvement was present. Then sensory system is intact. There is differentiation between cold and hot is present. Touch sensation is present. Triognosis and trapeesthesia is present. Tone is normal in all four limbs. Reflexes 2 plus, superficial reflex present, plantar extensor, no cluness. Power on, sir, actually, child presented to us and within 2 days, child has improved. So on presentation, his power was 1/5 on the entire right side and his hand grip was weak. But in 2 days, it was 4/5 with improved. There was improvement, quite a bit improvement present. Um, no meningeal signs, cerebral signs were normal, and other systems were also within normal limit. So it was my diagnosis was 7-year, 9-month-old boy, second by birth order, born out of non-consanguineous marriage, came with complaint of right-sided hemiparesis with right UMN facial nerve palsy. Facial nerve palsy has also improved, sir. With some known blood disorder, with no seizure, no altered sensorium, birth and developmentally normal, in a fully immunized child, is most probably a case of left-sided arterial ischemic stroke involving the internal capsule. Because the
I
right
missed that in
side
the earlier you said facial lower motor neuron type. What did you want
upper
to say?
motor, sir. Right upper motor
No,
neuron.
UMN.
So
UMN.
UMN and right side hemiparesis. So my localization was in the left side. And was ischemic stroke, like we discussed earlier. And internal capsule because it was dense hemiparesis, like involving upper and lower limb equally at the same time.
Go ahead. Investigations.
But actually, we had done a MRI.
No, but what about the blood disorder? Tell us about that. No?
But actually, all the investigations that were done were in Aurangabad, and we don't have any reports available from that hospital. And we did a MRI for the child, which came late, so I could not include it here. But it is suggestive of uh, acute non-hemorrhagic infarct in left centrum semi-oval, left frontal subcortical, and deep white matter with left hyperparietal region. Uh, few discrete T2 flare hyperintensity not showing restricted diffusion or blooming on GRE in right frontal and parietal region. Low-lying cerebral tonsils approximately 2.5 mm below, suggestive of benign tonsillar ectopia. On MR angio, they have given visualized segment of left ICA is narrowed in caliber with few segments showing loss of flow related signals. Paucity of cortical branches in left MCA is noticed.
You have not done any blood investigations.
Sir, we have done, sir. We had done USG to look for so we had done USG Doppler screening, uh, which showed no evidence of any thrombosis in major arteries. And
Blood investigations you don't have here.
I feel it's worth doing a lactic acid as a mitochondrial disorder because what is peculiar is a recurrent stroke which are recovering by itself. And I think that's a strong point to me in favor of a metabolic vasculopathy. Plus renal involvement, maybe hepatic at one time. And I think it's worth looking at. Now, I don't know whether a recovering stage will still show a CSF lactic acid, lactic pyruvate ratios. I have no idea. But I think that is worth looking at. And I would nearly bet on a mitochondrial disorder or any similar metabolic disorder of which we don't know enough.
Okay, so I think, uh, yeah. Any comments from the online audience? Any inputs?
Yeah, Rajesh, can I make a comment?
Yeah, yeah.
Yeah, I thought whether we should consider sickle cell anemia with G6PD deficiency because in sickle cell anemia we can get hyperhemolytic episodes, and that episode where there was splenomegaly and blood transfusion was needed whether that was an acute hemolytic episode. Also, sickle cell anemia is known to have vasculopathy in the cerebral vessels, and yearly sonography, that is transcutaneous Doppler, is done of the carotid artery to see for angiopathy. Because if the Doppler shows velocity of more than 200, then they give frequent transfusions to prevent a sickling related stroke.
No,
And
so what you're saying is right, Anjali. Only thing is, see here, if we go by that 25 transfusions history being correct,
yeah,
then there is nothing else that fits in except autoimmune hemolysis, where the transfused blood itself is getting hemolyzed. So that is a separate chapter altogether. Now, by
yes,
itself, if we look at sickle as a disease, we
yeah,
rarely see so many ischemic events. This child is giving history of repeated transient weaknesses multiple times, which gets better in 15 minutes, repeated episodes of hematuria, which have got better. All that is pretty unusual for a sickle history. So that
yes.
was the point. And I mean, you had any particular reason for adding G6PD to the sickle?
Because they can coexist and that can cause acute hemolysis, and the two can coexist, as well as sickle cell anemia with a, CNS arteriopathy. They
No, I
warrant
agree.
frequent.
Sickle with CNS arteriopathy, I agree. But I mean, at least we've never read or heard such cases where there are so many ischemic events. That is the point. And also, Sir's point is very valid, that any major hemolysis or even G6PD intravascular hemolysis should have been an episode of sickness with a lot of pallor, and that never came out in the history. But yeah, agreed. I mean, we are just discussing.
Yes, because that
He's
is
saying that
one.
when you know that this child is prone to CNS events, they keep them regularly transfused to prevent CNS
Correct,
events.
correct.
But
And
that is
also,
a, yeah,
We have
yeah,
got the CBC.
yeah, one second. Yeah, Anjali, go on.
and also that 8 months treatment could have been hydroxyurea, because they do continue hydroxyurea. This is just an of the
Yeah,
yeah,
possible, yeah,
just out of the box thinking.
correct. Any other inputs from anybody else online?
25 hemolytic events or rather
Mahesh,
hemorrhagic
your voice is
transfusions.
not clear.
1 minute, 1 minute, 1 minute. I'll just remove that. Yeah. Am I audible now? Audible now?
Yeah,
Speak a
better.
little louder.
Yeah, so basically 25 transfusion in 6 months cannot be explained by any bone marrow event. There is no obvious hemorrhage, so it has to be hemolysis. There is no question about it. Now, neither sickle nor J6PD can explain 25 transfusions. Even spirocytes is least likely, but huge spleen with jaundice. I mean, I've seen occasional child who required, but again, 25 is too much. So again, I think autoimmune hemolytic anemia stands out altogether. And with that autoimmune vasculitis, I mean, what Sir said initially looks like. Secondly, so many autoimmune happening in the same child. So are we dealing with some inborn immunodeficiency which is coming with autoimmunity? Because you are having a renal involvement with the hemolysis, with vasculitis. Are we looking at some kind of a generalized autoimmune? There are a few multi-systemic autoimmune disorders. We need to even consider that as a possibility. But I've never heard of 25 transfusions except a leukemia patient who may be on long-term treatment and getting those kind of things.
No,
But
no,
they
Mahesh,
have other
that
lines.
as we discussed, that same blood was only getting hemolyzed. There is no other. So it was they had formed auto antibodies against the thing, and in an autoimmune, it becomes very difficult to select which blood to
I agree.
transfuse. No?
I totally agree. So what I mean
Yeah,
to say, if at all, that is the only explanation for so many transfusions. There is
correct,
no other
correct. But
medical
the thing
explanation.
is, that is another part of the whole story. The actual crux of the matter is why are there so many ischemic events that we have not been able to explain.
But we have the imaging evidence of which you're talking only. So you're talking about embolizations, ischemic event,
No, no.
because sometimes moya kind of a thing do have those transient spasms rather than thromboembolic phenomenon. Can it be a spasm and then recovering like
Yes,
moya do come something
those
like that?
TIAs were spasms only. We have
Ha.
one established infarct due to a CNS infarct, but we also have those multiple renal involvements, na? So they
Yeah.
are also
Mm.
unexplained on the hemolysis. So the hemolysis is separate, and there is some other disorder underlying which is causing all this.
Mhm. Why you said renal involvement, Rajesh, just because of the cola color urine? Can you
But
give a
there have been
intravascular
multiple episodes of cola colored urine.
Yeah, so intravascular hemolysis can give rise to color urine. Apart from
No, no, but
hematuria,
yeah, but this history is not looking like intravascular hemolysis again and again.
hmm, okay.
Yeah.
It's
Chalo, anyway.
unusual.
Yeah. Come. Anything now? Any positive findings? The child has come,
TBC
but
on
he's
presentation.
recovered, so there are no positive findings.
Both have, look at the moon face cheeks, right? You agree, right? Yeah. Yeah, look at his face and that. Isn't it? Both have cheeks ballooned up. And so we must investigate that child also. I think what she has said is right. The things are different. That's so that's why this certainly looks more than him, and that's normal for him. Yeah, correct. Yeah, correct.
Completely normalized within 48 hours.
Recovery is time. Okay, sudden appearance, sudden disappearance. To me, first thing is a metabolic. Now we have many gaps in understanding, but the CNS looks at the metabolic vasospasms repeatedly.
Sir, can a porphyria present like this?
Yeah, he's
Sorry,
Everything is
Mahesh.
normal, sir.
Yeah. Can a porphyria present like this?
Porphyria.
Yeah, I mean, I have never seen one, but porphyria is known to have hematological and neurological hemiplegia, that kind of manifestation. But I'm not sure whether that can give rise to so much of hemolysis. I've not seen,
Hmm.
I think I've seen just one or two.
We'll
But
have
can
to
it
read
present
up.
like that?
Yeah, we'll have to read up. Okay, chalo.
Sir, ultimately, if we go to the microscopic, it has to be vasculopathic only. Multiple organs repeated, coming and going. Nothing can explain except vasculopathy at multiple sites. Only thing is why it's not inflammatory vasculopathy because it will not reverse. So spasm or something like that, temporary.
somebody was suggesting homocysteine. Yes. So some metabolic vasculopathy would be my first bet. Anyway, good case, good presentation.
TBC report, sir. WBC counts were 8,200, HbO 4.4, hematocrit of 13.5, with
Hemoglobin
MCV was
4.
high, sir. 107.9. MCV was high. Platelet 213, 213,000. And
There was Platinike also. You mentioned Platinike.
Platinum. And LFTs were normal, sir. OTPTs were 49 and 14. Bilirubin total was high, 4.7. And direct was 0.4. 0.4. 4.7. Total bili. 0.4 is direct.
It's a direct. Indirect. 4.7.
Urine HbMB was negative.
Again, next time we must know that. We have never been getting any feedback of what is the final diagnosis, which is unfair.
So the periorbital puffiness has somewhat returned. So because his LFTs, his RFTs are good, we've started him on Lasix.
Sorry, sir.
His RFTs are good, so we've started him on Lasix for the periorbital puffiness. So it's kind of resolving. We've sent a rheumatological workup. We sent a rheumatological workup, and ANA blot was sent, which has come back today. It is negative, and ASO titers were sent, which are also negative. So now we're planning further imaging to see if we missed something structural.
No, but last time we were discussing about malignancy and tuberculosis on the
The
fluid,
gene,
no?
so the pericardial gene export was negative, and the fluid cytology was also negative for malignant cell. So it has come back negative for both.
And how is the cardiac function now?
So cardiac function was always good. There was never any issue with the cardiac function. It was just impending tamponade. But since that was drained, the heart is functioning normally.
So child is now out of the ICU.
Yes, sir.
And the abdominal fluid ascites was there. What happened to that?
So that is also resolving now. But we're not sure of the cause yet.
Was a CT chest done that time?
No, ma'am, we planned a CT chest. It's going to happen on Saturday.
Okay. Please keep us informed.
Yes, ma'am.
Very interesting.
Okay. And last time, second case also, there was some feedback expected, no? Okay. Anyway, you remember? It was a Sam child. Come. Today's second case. Counseling in this case.
In this case, I think when you don't know what it is, you need to be reasonably honest to say to the parent. But the way to do is a little different. We would say that this child has had multiple episodes of disorder and multiple organs are involved. Therefore, we are looking at what must be the common cause, which is recurring and often involving different organs. We have not found out the exact cause, but every time it's getting better, we feel often naturally or sometimes because of our medication. And I think we will have to look at many other possibilities. We have tried to look at many experts, and so far, several tests have not shown correctly what it is. It is not so rare in medicine that you don't find the cause. More so because you are investigating a child when he is already naturally getting better. And also, all abnormalities also slow down, go down completely. So it is not. You will easily understand that when there is a theft, but you cannot locate the thief, it is nothing unusual because the thief could be anywhere and we have no idea where it could be, and we only try to locate him or spread out our nets. In medicine, we cannot open up and see every organ, so we have a limitation of looking from outside what is happening inside, either by some imaging or by blood tests. And therefore, in medicine, surely 5-10% of the times, in the best of the institutions in the world, the cause remains unknown. But we still hope to find out. We have many contacts. We will send opinions from experts. Today, with digitalization, even any expert from the world can be contacted. So be sure that we are with you, and we will try to see what this science can help us and how our contacts will also try to tell us where we can find. So we hope. But the good part is nature is working, or some of our drugs are working. And in spite of all that, today your child is absolutely normal, totally recovered from all paralysis. And therefore, that's a good reason and good hope to say that at one time we'll find out, or nature might completely get him all right. But we are with you. So I think this is the way we will have to counsel the parents, right?
Yeah, hello. Good evening, sir. So I would like to start the short case. 7-month-old female child, third by birth order, born out of non-consanguineous marriage, native to Uttar Pradesh, right now living in Dharavi, Muslim by religion, came with the complaint of fever since 3 days. Child was all right 3 days ago, developed fever, which was intermittent, undocumented, not associated with any aggravating factors, relieved on medication, and child was active in the interfebrile period. I would like to mention that the fever were high grade fever of one documented twice. One was 39 and one was 38. It was not associated with chills, not associated with rigors or rashes. Uh, I would like to tell you the past history. At the age of 4 months, child had on and off episodes of cough and cold, which were lasting for 1 month, for which local medication were taken at her native place. Um, Child's father was living in Mumbai. He called her to Mumbai, where he received uh, possibly syrup paracetamol and syrup amoxicillin that we know of, and rest other medication. Child has been symptom free for the past 1.5 months. There has been a complaint of poor weight gain compared to the siblings. Uh, there is no negative history, no significant negative history apart from the oil installation in ear, which was stopped 3 months ago. There is no history of bottle feeding, no vomiting, no loose stools. ANC history, 3 USG scans were done, all said to be normal. There was no fever or rash in mother. Folic acid and calcium were taken only for 15 days. Birth history, it was an institutional delivery at a native place. Full term, normal vaginal delivery. Weight was 2.17 kg. Baby immediately cried after birth, and there was no history of any jaundice or an ICU stay. Immunization is still date. Family history, there are three siblings, all three females, and this one is the youngest of all. All three said to be normal. No for complaints, no admissions. Developmentally, gross motor, there is only partial neck holding. There is partial rollover. The child cannot sit with support. Neither can she crawl. Fine motor, immature grasp is present. Language, bisyllable present. Child is able to say amma, abba. Social smiles present, interacts well with mother, recognizes family members well, and hearing vision is apparently normal. So out of the developmental history, only there is a developmentally gross motor delay. Rest all are fine. Impression on the history. Uh, 7-month-old female child, third by birth order, born out of non-consanguineous marriage, native to Uttar Pradesh, bought with the complaint of fever since last 3 days, with history suggestive of gross motor delay, with relatively preserved social and language milestone, with apparently no vision or hearing concern, with with poor weight gain in a completely immunized child.
What about diet history?
Sorry, sir. Diet history. She is mixed. She consumes mixed food. Uh, she has been exclusively breastfed for the first 5 months, after which complementary food was started. In complementary food, rice and khichdi with egg white were given. Sorry, sir, I was not able to
Come,
mention.
come sit. We'll discuss for 5 minutes. So, I mean, there are a lot of scattered things, but let's take some and discuss some. So presently there's fever for 3 days. You said 2 times documented high grade, but otherwise child is active, playful. So we don't really know what that fever is. Doesn't look like a bacterial infection for sure. Rest we don't know what it is.
Yes.
Okay. Now at the age of 4 months, child had on and off episodes of cough and cold lasting 1 month. So, I mean, in general, we are learning that if a 4-month-old comes with cough and cold, how would your thought process go and what all will you ask and what all will you think? So, first question is it common for a 4-month-old to get cough and cold again and again?
No, sir. Again and again, it's not common. It's uncommon, sir.
Why? You're right. Why?
There will be some immunity from the mother.
So more than immunity, if you're really talking of cough and cold, so there are, first thing is you need to clarify whether there is actually a cold. But if you're really talking of cough and cold, then its commonest reason is a acquired infection contact from somebody, which means again you have to confirm whether there is fever. And the point is that infants don't have so much contact with the community. So they are not going to get repeated viral infections. But here, two, three things are very important. One is whether there was definite fever or no. Otherwise, it's not infective at all. In which case, you have to think of reactive airway disease, which again is very uncommon at 4 months of age. So there are many unanswered questions, but these are the things that should come to your mind. That why should a 4-month-old get repeated cough and cold? What else will you think in a 4-month-old who gets repeated cough, doesn't actually have a cold, but what else will you think?
Sir, some cardiac.
Very good. So you should think of cardiac. Again, you should ask for difficulty in feeding, breathlessness. Of course, they won't have a cold. But the whole point is it should strike you that a 4-month-old getting cough again and again itself is unusual. So confirm cough, confirm cold, confirm fever, all that, right?
I think if it's going on for a month, how is he in terms of health? Is he feeding well? Does he sleep well? Does he play well? So is he doing well? If he's doing well, then I won't much bother about what's happening. That means there is, the other thing is that when there is a cold and cough, how much is he disturbed? Is he irritable? Does he not sleep well? If the mother says, no, everything is all right, then I think you discount all that as for 1 month because that is not a common age. But if it's something sinister behind, then there has to be something disturbing the life of a child. If that is not happening, I won't.
Was he treated at that time? Was he nebulized?
Sir, in the native place, nebulizations were given only 1 or 2 times. Sir,
Today, nebulization is given for varieties of reasons. So I understand the history very well. But even a metabolic acidosis will be given a nebulization because he is tachypnic. Okay. So, but possibly but the point that we are making is that we need to learn to ask many more questions. Okay. So this is what we are learning. You are right. You are just learning. But go on thinking. And if you start thinking, you will ask many more questions. Right?
So now there's a question or a thought that is it microaspiration due to GERD causing repeated cough, and that's why lack of weight gain also. So what are your thoughts on that? Any thoughts? So typically any infant who aspirates, what would be the symptoms? Sorry? With vomiting. So we have to ask for history of significant vomiting. That is one. Second, again, the cough, how bad is it? As sir asked, so aspiration would mean that the cough is quite significant, right? So we need to ask whether the cough was that severe, okay? And then that would tell us. Any choking episodes, okay? Fine. Now, what is the importance of oil instillation in the ear or any other oil instillation?
sir, those are actually nidus for infections. They are actually nidus for infection, like you are pouring an infection in the ear.
So it's an nidus for infection. But when they instill oil in the nose, it can cause a
Pneumonia.
lipoid pneumonia, right? By aspiration.
This is just an impression. We often entertain GR as a cause of recurrent respiratory problems. I was just wondering, in a 3-month-old child, there should have been a previous history of recurrent things. It should not have started at 3 months. The problem is worse then, and as he grows older, it started for the first time at 3 months. And when he was supposed to get GR, he did not get it. Was little unusual, though I don't know whether it can be a rule with that. And secondly, if had multiple aspirations, he recovered too quickly and without much intervention. Sometimes amoxicillin I have given, but with repeated aspirin going on, I think the illnesses were not that severe. And then further progress has been also very good. So therefore, probably that's what my thinking is.
Sir, breastfed initially till 5 months of age, exclusively breastfed, and after that complementary feeding. Yeah. So, so now this is again something that we all should think and exactly. So when you have to look at the whole thing as a story. So when they say that not gaining weight, you have to try to define that time. Suppose they feel that from 4 months or 5 months of age not gaining weight. In infancy, always first think of inadequate nutrition as the cause of not gaining weight rather than a disease. So confirm whether at that time what was the feeding history, whether it was adequate or inadequate. So whether the breastfeeding had started falling short, whether he had started asking for more frequent feeds, crying all the time. All this is very important to judge adequacy of breastfeeding. Similarly, not just saying history of complementary food given is not enough. Quantity, frequency, whether it was really adequate complementary foods or no. So in your mind, you have to judge, okay, is it nutritional inadequacy which is the cause of poor weight gain, or whether you are looking for something else, right? Which right now we don't have that data. And now coming to the development. So again, these are the gross motor is what you are saying now. But when was this achieved? Any idea? So again, this gross motor delay is a little striking compared to other domains which are normal. So two questions. Can it be just malnutrition? You said that there is a lack of weight gain. Assuming that it's not enough nutrition going in, can it be just that?
No, sir. Um,
Why?
so, malnutrition will cause a complete, it will also affect the other. Uh,
Okay. What do you think? How does malnutrition affect development?
Can be, sir. It can affect single domain also. He was not fed properly, maybe, and he was not able to. He did not have enough energy to hold himself up. So it can be, but with stimulus, his social was growing well. His because his hearing and vision was normal, so his uh, speech was growing well. It may affect growth and fine. This thing.
So basically, what we wanted to say is that malnutrition, first of all, does not affect cognitive milestones by itself. It can only affect gross motor to some extent. But neck holding and all due to malnutrition is a bit too much, means it's not palatable. So again, either you have to check whether that milestone is really right, and if it is really right, it cannot be attributed to malnutrition alone. Okay. So come now, tell us the examination finding.
Sir, on examination, child is afebrile, heart rate of 142 per minute, respiratory rate of around 30 to 32 per minute. Saturation is maintained, pulses are well felt, CRT is less than 3. On head to toe examination, rest all anterior fontanelle is around 0.5 to 0.5 centimeter. It admits only the tip of the finger. Rest all the findings are normal. Genitalia, skin color, no neurocutaneous markers. Everything rest is normal. Sir, anthropometrically, the weight is less than -3 standard deviation.
You
Height
have
is
to give us the values. You've not given us the values.
the weight is 4.75 kg, which is less than -3 standard deviation. Height is
Birth weight was
2.17 kg,
4.75 right now.
4.75 kg.
Gain in weight.
Which is coming right now at -3, less than -3 standard deviation. Height right now is 58 centimeters, which is less than -3 standard deviation. Head circumference at present is 39.5 centimeter, which is coming between -2 to -3 standard deviation. Mean upper arm circumference right now is 10.4, which is coming -3 standard deviation. Weight by height is coming between -2 to -3 standard deviation. Sir, the impression the child is suffering from severe acute malnutrition with microcephaly.
So did you ask about the details of breastfeeding history?
Yes, sir. So, the child is mother has a good milk output. Mother is saying that the child is taking milk very well, latching very well. She has demonstrated in front of us, and child is there is no history of crying, excessive crying. Child is able to take feed well, and child is sleeping well.
Go on.
So on systemic examination, cardiovascular system, S1, S2 is heard. There is no murmur appreciated. On respiratory examination, air entry is bilaterally good. Bilateral fine crepes are present on both sides. Sir, on abdomen, abdomen is round in shape, mildly distended with normal umbilicus. The striking feature is the liver is palpable. It was 5 centimeter liver, palpable below the right subcostal margin, and the liver span of 8 centimeters. Surface of liver is smooth, non-tender with soft consistency. Spleen is 3 centimeter below subcostal margin, non-tender, soft in consistency. Notch is not felt. There is no free fluid appreciated. Vowel sounds are present. This On CNS examination, child is alert, active, sensorium is good. The passive tone of the child is hypotonic. The active tone appears normal, sir. Posture of the child is normal. Power is more than 3 by 5 in all the four limbs. Reflexes, knee and ankle both are 2 plus. There is no clonal or any meningeal signs. Cranial nerves, sir, cranial nerves, the ocular 3, 4, and 6 would be partially tested and they appear to be fine. There is no facial asymmetry, so facial nerve seems fine. Rest of the cranial nerves couldn't be tested, sir. Um, on 360-degree examination, when you try to pull to sit, there is a slight head lag that is present. On axillary suspension, there is feeling of slippage, and on ventral suspension, the head is at the level of the plane of the body, not rising above it. Sir, the feature is the abdominal features were not present and were not noticed by the parents. It was noticed only after he came here. That
Come, we'll discuss. So he gave us the breastfeeding history. So what do you make out of that? What is your inference?
Frequent breastfeeding, he is saying. If the child could sleep properly after feeding, there was good milk output, the latching was good, and the child sucking reflex is also good, then there is no discrepancy with the breastfeeding.
So if on adequate breastfeeding he is not gaining weight, then what does it mean?
Can be some chronic infection the child is feeling in the chronic disease, something that is present, some metabolic disease that the child or malabsorption is there, the child is unable to absorb, gut is unable to absorb, and liver.
So good, you are telling me all causes, but now think of each cause and tell us which is applicable in this child. So when we say chronic infection, any thoughts? Can this be chronic infection? What should be the presenting complaint of a chronic infection? Simple, common presenting complaint. Yeah, lack of weight gain is there, but something which should always be there in an infection. Fever, no? There should be fever. Okay. Here the presenting complaint was not there at all. You just said some cough and cold, no fever, right?
fever was the presenting complaint, but it was just for 3 days.
That
So
is now,
now,
3 days. So that's not a chronic infection,
yes,
right? Then in that old cough and cold, you said for 1.5 months the baby was fine. So all that is very, yeah, means it doesn't fit in. Then you said malabsorption. So what are your thoughts on this being malabsorption? Again, from the history, you should be able to make out.
Sir, there is no,
Bol. Bol.
sir, there is no complaint of loose stools or
Very good.
vomit.
Very good. So there has to be lot of loose stools if it is malabsorption on breastfeeding causing a failure to gain weight, right? So that is not there. So that is out. So what are you left with?
Liver part for the metabolism.
Metabolic disorder, you mentioned something. So some kind of a metabolic or a neurodegenerative disorder. Of course, there are gaps there also in your milestones history, but that is something which we will keep in mind, right? Now, what do you make out of the hepatosplenomegaly that you found out? How will you analyze that? We've done this many times, liver spleen. So liver enlargement can be divided into 4 areas clinically. So which of those areas are here? Parenchymal disease, then biliary tract disease, then venous vessel disease, and fourth, RE cell disease. So this fits into what? Does it look like a biliary tract disease? Why not? No jaundice. So that is out. Does it look like a vessel disease? No. Why? Why not? You're right. No signs of ascites. So that is out. So you are between hepatocyte disease and RE cell. Now this child has not gained weight. So it could be hepatocyte dysfunction. So now think deeper and tell me, does it look like hepatocyte dysfunction? Does it look like a primary hepatocyte liver disease here? Think and tell me. Come on.
In a primary hepatocyte disease, I would expect the child not to be uh, active with a good sensorium. The child would probably be more irritable, sick, rather than appearing like a well child, but less grown.
Refusal to feed and vomiting features will be there.
So we are talking of lack of weight gain as a hepatocyte dysfunction. So what are the other hepatocyte dysfunctions? Bleeding, then jaundice, no. So jaundice should be there, no, for a liver disease, hepatocyte disease that has come up at such a young age and is going on for such a length of time, right? Okay.
I think we have discussed the history part, which we need much more information. Why adequate breast milk and still the baby is not doing well. But if you go by that simply thing, then that means uh, any child who is on breastfeeding not gaining weight, there is something wrong with the host. That much we know. So all that we have is a significant hepatosplenomegaly. Without anemia, so hematological disorders are out. Without jaundice, so liver disorders are out. So what RE cell? RE cell, therefore, only two types. One, a chronic infection. Another is a storage. Could it be infantile Gaucher's or Niemann-Pick's? Failure to thrive, delayed milestone.
What basically what sir is saying is we just discussed liver 4 parts. So we came down to RE cell. And RE cell is storage, as sir said. Now you have to connect storage to the hypotonia and the delayed motor milestones and the failure to grow and come to some common thing.
So basically, if you look at the storage, so metabolic disorders, if it's a protein metabolism, there would be vomiting, seizure, whatever. So this is not. If it is a carbohydrate, then typically there would have been hypoglycemic episodes. So this is not. So could it be lipidosis? Okay. Now this child has started in after 3 months of age. The failure has come right through beginning. So most of the leukodystrophies that come up with liver and spleen come up a little later at maybe 5, 6 months of age, like Tay-Sachs or Shandorf's. They have storage. Okay. And therefore looks unlikely looking at it. But what is predominant is there is a microcephaly. Now, what does it mean? Microcephaly almost rules out a metabolic disorder because the babies are born normally with normal head circumference and thereafter may not grow much. But if it is significant microcephaly, then it is either an antenatal or a perinatal. Now, there is no history of any kind. So, could it be antenatal? Now, why antenatal have liver and spleen? So, maternal infection transmitted, and not necessarily that every time you will get low birth weight, etc. And therefore, one that could be a chronic infection. Okay, is it an active infection or an infection which has died out and you are looking at a damage? What do you think? You get my question? Is the disease active or it is burnt out?
Is he growing well? So
And
that
therefore, it is likely to be an active disease. Okay. Now, what active disease? It's already involving the brain and the liver and spleen. And therefore, to begin with, could it be toxoplasma? Could it be CMV? So we start looking at all that. Uh, but those are typically a maternally transmitted one. Uh, do you think it could have been a congenital malaria doing it? Do you think it's a congenital TB? Do you think it's a retroviral HIV? These three are more commonly seen than our torch. What is your comment on all that? Congenital TB, long term, okay, fever is not there for infant. Low grade fever is missed. So he is failing to thrive. He has got liver and spleen. We have said congenital infection. Why not congenital TB?
So we need to have history. It is contact related. So we need to have a contact.
Contact is not known. You're right. You're right. But give me a better explanation.
genital TB means this baby is 7 months old and got TB at birth. Or so what would happen on over 7 months? Hmm?
It's likely to disseminate and the child will become very, very sick by this time.
And therefore, the point I want to make is if it's a congenital infection and if it's an active infection, it's slowly progressive infection. Okay. And it has done a damage to the brain, but not an active brain disease today. Two things are different. So all these types of congenital infections, toxoplasma may fit in. It could have a wide spectrum event. But that brain damage makes me feel that
So there's another small point. His length, he said, is 59 and head is 39. Now, going by the Diane's formula, this head is normal. It is not microcephaly.
then we throw that out totally. Okay. That's a good point because what you're talking about is head and length. and then it's not microcephaly, in which case you leave that totally, that it was antenatal or so. And then we start thinking whether this is really a metabolic problem. Metabolic problem coming with storage without hypoglycemia is some kind of a
Lipid
lipoidosis.
disorder.
Now we will not know clinically what it is. We may look at there is a hypotonia, you said.
Yes.
Now, if it was a spasticity, leukodystrophies would have come in. The eye signs would have been there. So possibly not. If it's a gray matter disorder, then seizure would have been the prominent feature. So that is not there. So I think we will have to look at metabolically what is.
I think little more assessment of the mental milestone, the cognitive milestones was important. And if you have to correlate microcephaly, which it probably is not, normal physical development and I mean normal mental development and abnormal physical development couldn't be there. There would be parallel mental involvement also, or maybe the other way around. That the child is not affected so much in physical but mental. So with microcephaly and little bit of more details about now when you says bisyllabus, what do you exactly mean by bisyllabus? Is it Baba and he stops or Baba goes on? If Baba goes on, it's okay. Baba he stops is unlikely. It's 7 months child. So little bit because when you say that gross motor is normal, and I mean gross motor is abnormal and only the mentals are normal, then your thinking goes more on the physical diagnosis and less of CNS diagnosis. And if it is the other way, if it is otherwise equally affected, then you think of neurodegenerative or global delay. Then from global delay and also involvement of the motor system. If nutrition is ruled out, nutrition also going to be a factor in this particular child. If we go in detail, just weaning started means what? How much was he taking? 2 spoons 3 times a day is no weaning. Was he a satisfied child? So little more details of.
Just a point to make that not all neurodegenerative disorders or metabolic disorders are non-treatable. But we need to look at which we should not miss, biotinidase, okay, or multiple carboxylase. So biotin and vitamin B, yes. So we should not. No, PKU, etc. is a diet restriction. So you need an early diagnosis. But I'm trying to emphasize on biotin dependent, which are curable. If picked up early, then there will not be a permanent damage. And what Dr. Khare said is early diagnosis of PKU, etc., or an MSUD can hopefully minimize the brain damage. But that we need to pick it at the birth or as early as possible. But there are vitamin B complex dependent neurodegenerative disorders, where if we pick them up, we can at least stop their progression.
The baby is not here, no?
Sir, impression, 7-month-old female child, third by birth order, born out of non-consanguineous marriage, native to Uttar Pradesh, brought with the complaints of fever since the last 3 days, with a history suggestive of gross motor delay. The developmental quotient were coming 90%, with no hearing or vision concerns, with microcephaly, with hypotonia, with hepatosplenomegaly, is probably a case of first thing that I would like to put was torch infection, neurometabolic disorders, mitochondrial disorders, and then storage disorder.
Go ahead. Any investigations have been done?
Sir, CBC was done. Hemoglobin is 7.4. Hematocrit is 21.4. WBC counts are 17,000. Uh, lympho predominant. Lympho is 13,000. Platelets are 2 lakhs. Sir, renal functions. BUN is 9. Creat is 0.4. Sir, we have this much only investigations.
sonography, anything abdominal
No,
sonography?
sir, we have not yet done the sonography. We are planning to do the sonography and the metabolic workup of the child.
This child was unwell or what? Why couldn't we bring the child today?
Sir, the child actually is in the ward only.
Acha.
Yes, sir.
The DQ of 90% is a typo. Huh?
Yes, sir. So, DQ is coming around 87 to 90% because,
So what do you mean by that? Explain.
sir, out of all the four, the gross motor was delayed and the partial neck holding, the partial rollover, we are expecting around to happen at 3 to 4 months. And the child right now is 7 months old. So around 4 months of delay is present.
So that's not 90%, no?
But calculating with the total fine motor.
ऐसे नहीं. You should give the DQ in each domain separately. Yes.
Okay.
You can't club everything because that, in fact, that's the way you analyze. So your DQ in as per your this in fine motor and language and social seems to be 90%, but in gross motor seems to be 50%.
Okay.
That's what it looks like.
Yes.
Of course, we need to get into more details, right?
Yes.
Fine. So now, once again, next time you will tell us more details of the first child, the reports at Aurangabad, whatever you can get, and our local reports also, right? And I'm sure his whatever his autoimmune hemolysis is not sorted yet because today also you said his hemoglobin was 4. So that problem is going on. Yeah. So the problem is going on. So you will get some abnormalities in the blood now also. So we should get to know what was picked up, right? And for this one also, next time you please tell us.
Yes.
Right? Any inputs from the online audience? Any questions? Any comments?
None, Rajesh. Excellent
Okay.
second case as well. Both cases were wonderful. We'd like to know what the outcome is. Whether second case they're planning an MRI.
I think they have
Ma'am,
just started
we have just
working
start-
up.
we have
So
just started the workup, but definitely MRI seems to be in the plan. Right?
Great. Thank you so much for such lovely presentations. Thank you, Rajesh. Thank you, Amdekars sir, and all colleagues.
thank you. Thank you, everyone.
Thank you,
We meet
Pallavi.
next Thursday again at 5 o'clock. Thank you.
Yes.